All right. Good morning, everyone. Welcome to today's webinar. And it is titled Achieving Health Equity, Tools to Move Forward. My name is Vanessa Kittleson, and I am a member of the Quality Management Team at Hennepin Health in Minneapolis. So today's webinar is presented to you by a collaboration of Minnesota Health Plans working to ensure a healthy start for Minnesota children by concentrating on improving services provided to pregnant people and infants with a particular focus on reducing racial and ethnic inequities. The health plans collaborating in this project are Blue Plus, Health Partners, Hennepin Health, South Country Health Alliance, and UCare. The webinar is being recorded and will be available for later viewing on the Stratus Health website on the Health Plan Performance Improvement Project Healthy Start page. There will be an evaluation for you to complete at the end of today's presentation. It will display as you log off the webinar, and by completing the evaluation, you will receive a certificate of participation. So during today's presentation, please submit your questions via chat, and our presenter will respond to the questions at the end of the presentation as time allows. So I'm honored today to introduce our guest speaker, Dr. Veronica Gillespie-Bell. She joins us from New Orleans, where she is an associate professor for Ochsner Health and a senior site lead and section head of obstetrics and gynecology at Ochsner-Kenner. She is the Director for Quality for Women's Services for Ochsner Health System and the Medical Director of the Minimally Invasive Center for the Treatment of Uterine Fibroids. Dr. Gillespie-Bell is also the Medical Director of the Louisiana Perinatal Quality Collaborative and Pregnancy Associated Mortality Review for the Louisiana Department of Health. In this role, she leads initiatives in the state of Louisiana to improve birth outcomes for all birthing persons in Louisiana and eliminate the Black-white disparity gap. It is with this wealth of experience that she leads us today on how to take our knowledge about health inequities and medical racism and turn it into action around dismantling systems for the improvement of healthcare for everyone. So thank you, Dr. Gillespie-Bell, for being with us today.
Thank you so much, Vanessa, for that kind introduction, and thank you all for having me today. And as Vanessa's mentioned, we're going to talk about health equity, but also the tools to move forward to improving outcomes. For disclosures, I have no financial disclosures related to the content of today's lecture, and we'll be talking about understanding how quality links to equity. We'll discuss the importance of looking through a lens of equity, describing those barriers to providing equitable and respectful care, and then identify practical steps to be undertaken in quality improvement to support equitable and respectful care. And I'm going to talk about it through the lens of a quality collaborative. As Vanessa mentioned, I'm the medical director of the Louisiana Perinatal Quality Collaborative. And so I'll talk about what we've done here in Louisiana to address equity. So first of all, linking quality to equity. It really is a seamless link. If we think about what quality is, the Institute of Medicine defines quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And the Institute of Medicine says to get to quality, you have to have several domains. Initially, they identified 5 domains. Care has to be safe. It has to be effective. It has to be patient-centered, timely, efficient, if it's going to be good quality care. They came back later and said, we have this 6th domain, it's equity, quality. To achieve quality, we also have to have equity. And they finally came back and said, you know, equity does not need to be a domain that is isolated and by itself. We cannot get to quality if we do not have equity driven into all of these other domains. You cannot have safe care if it's not equitable. You can't have effective care if it's not equitable. Patient-centered care if it is not equitable care. And when we're trying to think about quality and thinking about equity and how do we measure that, we know that health disparities are the health outcome that measure our progress towards health equity. And I'm sure many of you have seen this picture. When we talk about equal care, when we're talking about equitable care, is not the same as equal care. So equality and equity are 2 different terms. Although they get used interchangeably, they're really 2 different things. Equal care is the picture on the left. That means that individuals get the same resources regardless of their need. And you can see that when we give the same resources, we don't always get the same outcome. So for this first individual, that resource is too much. For the second individual, the resource is just enough. And for the third individual, even though they've gotten the same resource, that it's not enough for them to get to that optimal outcome. And when we talk about equitable care, everybody gets what they need to get to the same outcome. In this picture, the outcome is looking over the fence. When we're talking about quality and equity in healthcare, we're talking about optimal healthcare and optimal health outcomes. So just another way to look at that, again, equitable care means the same quality of care, not necessarily the same care or the same resources or equal care, but the same quality of care. And what we're trying to always do is to narrow this Black-white disparity gap. And so that shows that we are improving our care. Just an example here, and this is from breast cancer and looking at Chicago from 1990 to 2005. If you look at just the blue line, you would say, wow, outcomes are improving. We went from 20% to down to about 15%. However, if you look at the Black rate amongst breast cancer, you can see this improvement is not really happening at the same rate. So improvement is happening for one group and not the other. This means we are not providing the same quality of care for individuals that are Black and individuals that are white. And so if we think about that in terms of maternal and infant health disparities, what do we see? And these are things that we see if we look nationally, and then I'll give you also just some data for where we are in Louisiana. So we know that nationally, Black women are 4 times more likely than white women to suffer a pregnancy-related death. We know that the rate of preterm birth among Black women is 50% higher than that of white women. We know that the infant mortality rate for Black infants is 2.3 times higher than that of non-Latino white infants. And as much as we talk about, and we're going to talk about social determinants of health, as much as we talk about that, even when we account for social determinants of health, we still see disparities. And so if we look at severe maternal morbidity, the rate of severe maternal morbidity for a Black woman with a college degree is twice that of a white woman with a high school diploma. And so this is all leading to the fact that we have inequitable care. That's what leads to these health disparities. And if we all in healthcare have taken an oath to provide care to our patients, to do no harm and to help patients to get to good outcomes, why do we have inequitable care? So first, we need to look at health disparities and health care disparities. Again, these are terms that are used interchangeably, but they're a little bit different. Health disparities are looking at outcomes. So all those things that I just listed for you in the previous slide about infant mortality, about maternal mortality, about preterm birth, those are health outcomes that show health disparities. But in addition to that, we have health care disparities. And those are the differences in how we deliver care, those differences in quality of care. So just some examples of inequitable care and those health care disparities. We see that Black individuals are less likely to be offered preventive services such as cancer screening, influenza vaccine. We see that Black individuals are less likely to have adequate treatment of pain. We see that Black and Hispanic or Latino women are less likely to receive bypass surgery, even when it's medically indicated. And then we see women are less likely to undergo appropriate cardiovascular testing. And so again, these are differences in how we deliver care. If we think about the influenza vaccine, we know that from October to February, it is recommended that everybody get a flu vaccine. So why is it that Black individuals are less likely to receive that offer? And so really it comes to something called implicit bias. And I know that in previous, through your webinar and through previous series, you've talked about implicit bias, but I'm going to get into that a little bit too. So if we look here and we think about implicit bias, so implicit bias is also known as unconscious bias, and it's defined as the attitudes or the stereotypes that affect our understanding, our actions, and our decisions in an unconscious manner. And so I like to show this picture because I think this is an example of the unconscious and implicit bias that we have in society. Just not even thinking about healthcare, but just one in society. So if you look at the picture on the left, this is during the Black Lives Matter protest on June 3rd. And this is mostly Black and brown individuals. And you can see that the police are meeting them in riot gear. Whereas if you look at on the right side of the picture, where this is mostly white individuals, and this is during the riot on the Capitol on January 6th, you can see that the police met them in just their regular uniforms. And so what this picture, and juxtaposed, I think it really stands out. What this picture is saying that in society, when we see a group of Black individuals, we are expecting violence. And so we are prepared for that. And so unconsciously, we think of Black individuals as being violent. Whereas if it's a group of white individuals, again, the thought is that, well, they must be here to just express how they feel, and there's no need for violence, where we know the Capitol event was a very violent event. And so again, this just speaks to our biases as a society. Now, before we start pointing fingers, we're going to take a moment of reflection. So I'm going to ask a question, and I want you to if you know the answer, I want you to chat it in the chat box. I'm going to open the chat so I can make sure I can see what your responses are. So a boy and his father are driving down the road and they get into a car accident. The father is killed and he's taken to the boy is taken to the hospital, and it's determined that the boy needs surgery. The surgeon comes out and says, "I cannot operate on him. He is my son." And so the question is, who is the surgeon? So I'm gonna go through it one more time. A boy and his father are driving down the road. They get into a car accident. The father is killed and the son is taken to the hospital. It's determined that he needs surgery, and the surgeon says, "I cannot operate on him. He is my son." And so the question is, who is the surgeon? And so for all of you in the chat, you got it correct. The answer is that the surgeon is his mother. When I tell you that, as much as I do obstetrics, I am a surgeon. I operate every Tuesday. My clinical interest is in fibroids. I do a lot of surgery. When I was asked this, I said, oh, of course, he must have two fathers. We have to think about all different types of parental relationships. Did not even occur to me that his mother was the surgeon. I am a female surgeon, and that is not what pops into my head when I hear the word surgeon, probably because my initial interactions with a surgeon were on television, and surgeons were always men. And so that was so when I hear the word surgeon, I think man. And so it did not even occur to me that would be his mother. So why is that? So our brain likes to take shortcuts. We are inundated with all of the information that comes to us at any moment in time. And our brain cannot possibly process all of that information. So we take shortcuts. And the way we take these shortcuts are by seeking out patterns. And these patterns come from our experience and our social conditioning. So for me, my social conditioning was that I thought of a surgeon as a man. I did not see a female surgeon until I was in residency. I had not seen a female surgeon. So my initial growing up, that was a surgeon was a man. And so that is the shortcut that my brain thinks, so that when I hear surgeon, I think man. And so we all have these biases. They are, again, a natural process. But in healthcare, these biases can affect the way we deliver care. And this is why we see those differences in how we deliver care. And in particular, when we think about minorities and we think about people of color or even gender biases, but especially with people of color, depending on who you are as a provider, your shortcuts are coming from social conditioning. And how are Black and brown people, how are they displayed in social situations, in social media, on television? They're not displayed in positive ways. And so that makes us as a society develop these negative biases that then affect how we deliver care. Just to take you through a short history lesson, let's talk about, in particular, how we have developed biased beliefs about Black women. So throughout time in society, there have been 4 archetypes that have been developed through time to describe Black women. And so beliefs have come out of this, and you will, hopefully, as I go through this, you'll understand what I mean by this. So there's 4 archetypes. One is Mamie, Sapphire, Jezebel, and then the welfare queen. So I'll take some time to go through each of these. So Mamie is an archetype that developed during the Jim Crow period, and it portrayed women to be dark-skinned, and in society that was seen as ugly, middle-aged domestic workers. It's a stereotype Black women as being obese, maternal figures, desexualized, loyal to white families. They were deemed as unattractive, and this was not to threaten white women, as there was no way that her white husband would be attracted to someone that looks like this. And so this is how Black women were portrayed during the Jim Crow period. They were stereotyped as taking care of the white family's children, but not her own. So think about that, and think about how we think about Black women, especially if we see a single Black woman and her children. What kind of stereotype and bias comes into our mind, and where did that bias come from? And so I would pose to you that this idea of Mamie back from Jim Crow has perpetuated through history, and this is how we tend to see Black women today. Now, moving on from Mamie, then we developed the Sapphire archetype, and so this was the sassy Mamie. And it was named for Sapphire Stevens, which was a character on the Amos and Andy radio show. That was from 1928 to 1960. And then it actually went on television from 1951 to 1953. So again, thinking about individuals and how they have developed their biases. And if it's through social conditioning, we're talking about now through television and radio. It portrayed Black men as being lazy, confused, unemployed, financially inept. And it portrayed Black women as domineering, aggressive, and emasculating, overbearing, stubborn, rude, loud. And it led to this angry Black woman stereotype. So when we think about the angry Black woman, it started to come from this Sapphire archetype. To this point, there was a study that was done where they asked different individuals about different characteristics that they would use to describe Black women. And this was in 2013, not in 1963, in 2013. The participants reported that Black women are overweight, confident, they're not feminine, they're aggressive, they have big butts, they wear weaves, and they eat fried chicken. And so again, thinking about Mamie and then this Sapphire, and then I'm gonna tell you about the other 2, you can see how this has developed this bias towards Black women. Now, this is interesting to think about this, the angry Black woman stereotype. It actually is a psychological way of dampening the voices of Black women, because a lot of Black women remain silent because they don't want to be seen as the angry Black woman. We especially see this in healthcare, where Black women tend to not speak up when they know something is wrong with their body or they know something is wrong in healthcare, because they don't want to be seen as the angry Black woman. Moving on from the Sapphire archetype, then we have Jezebel. Jezebel was stereotyped Black women as being hypersexual. And this began when Europeans were traveling to Africa, and the African women were scantily clothed compared to European women. And they used this to justify slave owners raping slaves, and it was perpetuated in art and novelties and media. And you can see this is an example here. This was a slogan for LBJ when he was running for president. And you can see that this Black woman is pregnant, and the slogan is, "I went all the way with LBJ," also making fun of her vernacular and how she speaks. And then moving from Jezebel, then we have the welfare queen. And so this stereotypes Black women as being uneducated, single mothers who who have children to take advantage of public assistance. And again, this is on top of the Mamie archetype that says Black women don't take care of their children. And so this was a term, this welfare queen was a term that was coined after Ronald Reagan used the life story of Linda Taylor during his 1976 campaign. He came up with the welfare queen. Now, Linda Taylor was a woman who did use she used the, I'm not gonna say use the welfare system, but she manipulated the welfare system to make a lot of money. Now, whether Linda Taylor was Black or not, that was actually never decided, or she never said she was Black. She could sometimes pass for Black, sometimes pass for Latina. But what got from that, whether she was Black or not, what got assigned to her was that she was a Black woman and was scheming the welfare system. It became a political platform for disdain of public assistance programs. So David Duke used this platform to recommend giving money to women on welfare who would get Norplant. So if a Black woman said they would get Norplant, he said, well, we should pay them more money. So now we are getting into reproductive justice and trying to control the Black population. And in reality, according to the National Assistance Program Report Series in 2013, 34% of white households participated in SNAP compared to 23% of Black households. So again, just this view that Black women are taking advantage of public assistance. And again, these are archetypes, but they've been portrayed in the media, who have then now made this social conditioning and biases in all of our minds. But in healthcare, this has, again, real ramifications. So just another idea of bias and thinking about medicine. So if you look on the left, the guy that's standing in the Black coat, that's Marion Sims. He's known as the father of modern gynecology. He invented the speculum. He invented the vesicovaginal fistula procedure. All of this he did by operating on slave girls. At that time, even though anesthesia was available, he operated on them without anesthesia. And what went into the textbooks is that Black individuals don't feel pain in the same way. And so that bias became a belief. And so what you see on the right is a graph from a study that was done at the University of Virginia. They surveyed about 200 white residents and white medical students. And over half of them believed that Black individuals don't feel pain in the same way as white individuals, because Black people have thicker skin, they have different nerve endings. And what the graph is actually showing is that the higher their false belief was that Black individuals don't feel pain in the same way, the less likely they were to give them appropriate pain medication. So again, this is just an example of how bias becomes belief and how it is so dangerous within healthcare, because it affects the difference in how we deliver care. And this is why everybody does not have the same quality of care. The other way that we see bias and bias play out is in microaggressions. So a microaggression is a comment or action that subtly and often unconsciously or unintentionally expresses a prejudiced attitude toward a member of a marginalized group, such as a racial minority or a gender minority. And there's three types of microaggressions. We have micro assaults, micro insults, and micro invalidation. So a micro assault is a conscious and intentional action or slur based in a biased belief. So one I use for an example, my husband and I were in Italy. My husband likes custom-made suits. We go into a store in Florence, and as soon as we went into the store, one of the clerks or the attendants in the store was almost in my husband's back pocket, following him around the store. Never offered to help him. Never said, "Is there something that you're looking for?" He was following, it was obvious, he was following him around to make sure that he didn't steal, because certainly a Black man coming into the store was there to steal. And so again, that was a conscious and intentional action on behalf of that store clerk based in his biased belief. A micro insult is a verbal or a nonverbal communication that subtly conveys rudeness and insensitivity that is demeaning to a person's race, ethnicity, or gender. One that I've heard before, you don't sound Black. So how are Black people supposed to sound? So because I am articulate and I pronounce my syllables, then is that something that's inappropriate for Black people to do? So again, it is not a verbal communication that is actually being insensitive and it is demeaning the Black race to say I am so articulate to be Black. A micro invalidation is a communication that subtly excludes, negates, or nullifies the thoughts, feelings, or experience reality of an individual. An example of this, when someone says, "Stop Asian hate," and someone responds with, "Stop all hate." Well, yes, nobody wants hate. And we're not to say stop Asian hate doesn't mean that we want hate to happen in a different group. But to say, when someone says stop Asian hate and somebody respond with stop all hate, that is nullifying the reality that Asians are feeling or have been feeling in the last several months. Asian Americans have been feeling the last several months when they are scared for their parents and grandparents to walk down the street because they don't know if an act of violence and hatred is going to happen to them. And so again, that's that micro invalidation. And the thing in healthcare is with these biases and with these microaggressions, we are foolish to think that we walk into the hospital and all of a sudden these go away. They don't. And so we have to think about how do we address them and how do we get to an area of respectful care. So we've been talking about equity and equitable care, but equitable care is respectful care. And this idea of respectful care actually came out of other countries. It did not come out of the United States, but other countries in Africa and in South America, where they were trying to convey that respectful care is human rights, that every human deserves to be seen as an individual and deserves to be respected. And even though this came from the White Ribbon Alliance and came out of countries that we would say are third world countries, it is very applicable here in the United States. Everybody does not have respectful care. Just an example, May 27th of 2020 and in April of 2020, this is a story, this particular story that's on the slide is from something that happened in February where lawmakers were trying to change individuals giving birth in jail and giving birth alone in jail. The story that from May was in Texas. The woman gave birth in jail and the baby died 10 days later. And the woman was arrested for assaulting a family member. So we're not talking about from murdering somebody or stealing something. She was there for assault. But probably what happened is the bail was, or her bond was set, bail or bond was set so high that her family couldn't pay it. So then she couldn't get out of jail and she was probably waiting for her trial. And so she had to give birth in jail. And when these birthing persons give birth in jail, they're usually still shackled. They're alone. They're not offered pain medicine. They're not offered support. And so that doesn't sound very respectful to me. And then not just those individuals that we think are quote unquote vulnerable individuals, but this on the left is the story of Dr. Alicia Liggett, who was a family medicine practitioner and family medicine doctor. And she talks about how nobody talked to her during her birthing process. Nobody explained anything. They were doing care to her and not with her. And then on the right, we have Serena Williams, and many of you probably know her story. She has a history of blood clots in her legs. And after she delivered, she was feeling short of breath and she was telling the nurses, I feel short of breath. I think I have a pulmonary embolism. I have a history of DVT. I need a CT scan. And she basically had to beg before somebody heard her and actually did the CT scan and found that she was having a pulmonary embolism, which she could have died from. And so again, that is not hearing the voices of our patients. That is not respectful care. And I like these quotes when we think about what respectful care is and what respect is. Jackie Robinson says, I am not concerned with you liking or disliking me. All I ask is that you respect me as a human being. And so it's not about being polite. It's not about being nice. Respect is more than that. And then Lawrence Stern says, respect for ourselves guides our morals, but respect for others guide our manners. So in the way that we treat others. And then respectful care is patient-centered care. So it is providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patients' values guide all decisions. And Picker has 8 principles of patient-centered care, and these are very consistent with the areas of the White Ribbon Alliance on respectful maternal care. So that's respect for patient preferences, that is coordination and integration of care, that's information and education, providing physical comfort, emotional support, having involvement of family and friends in the patient's care, continuity and transition, and then access to care. And again, this is, as we talked about with healthcare disparities, I am convinced, nobody goes into medicine wanting to give bad care. So then why do we not get there? Why do we have these obstacles? One is bias, and we've already talked about that, but the other is culture, the culture of the healthcare system around respect. Time is an obstacle, and then understanding the respect model. And so I'll take some time to unpack those. So when we think about respect, and in a culture of respect, people perform better, they're more satisfied, innovative, they display greater resilience. And this means respect for colleagues as well as respect for patients. It's really hard to be respectful to a patient if your colleagues are not respecting you. So it's about that culture and that environment. And then equity, when we think about this culture, equity has to be a part of it. It has to be an integral part of our values. That means acknowledging that disparities exist and then viewing inequity as an injustice. What happens when inequity happens in your environment? Are there any repercussions? Again, I won't go through all of these, but these are how we see disrespect in healthcare, in the culture. Disrespectful behavior, attitudes, rolling eyes, sarcasm, shaming, all of those things show disrespect either to authority, to your colleague, or to your employees. And again, it's really hard to deliver respectful care to patients if you are not having respectful care yourself. So thinking more about equity, now thinking about the makeup in our healthcare system around equity, that structure part. We know, and this is from the AAMC, the American Association of Medical Colleges in 2018, they identified a significant disparity in race ethnicity of active physicians. This was a survey of about 42,000 physicians, active physicians, and Blacks accounted for only 5% of all active physicians. Latino and Latina physicians accounted for only 5.8%, and then 64% are male. So it's very difficult to provide care, or not to provide care, I shouldn't say that, but it shows a lack of equity in the healthcare system when we don't reflect the patients that we serve, when we don't look like the patients that we serve. And then if we think about leadership, so this was a study done by Korn Ferry where they surveyed 200 hospitals and healthcare systems, and 55% of them reported overlooking women for leadership positions because they were women. And then almost 80% of the healthcare workforce is made up of women, but only 19% of hospitals are led by women, and only 4% of healthcare companies have a female CEO. So again, when we're thinking about equity, do we have gender equity in our leadership? And if we don't have gender equity in our leadership, what does that say to our patients that are coming in? We mentioned, in addition to bias and equity and culture being an obstacle, time is an obstacle for providing respectful care and care that is good quality care for everyone. And so this is from another study that said 27% of OBGYNs spend about 17 to 14 minutes with their patients. The majority spend 13 to 16 minutes. 27% spend 9 to 12 minutes. How can you provide respectful care and make sure that you're giving quality care if you don't have time to listen to your patient? to talk to your patient, to give your patients that platform. And this is not because physicians want to do that. Physicians report that lack of time with patients causes them decreased job satisfaction and physician burnout. But a lot of this is around our pay models that make it so we have to see so many patients and squeeze so many patients in a short amount of time. And then I mentioned this respect model. And so respect just stands for rapport, empathy, support, partnership, explanations, cultural competence, and trust. And so these things have to be in place to make sure you're giving respectful care. Moving through that, now to change. What do we actually do? How do we get there? How do we provide high quality care that is patient-centered and respectful? Really, it takes a multitude of entities to make sure this happens. And so I'm going to talk about each of these, thinking about healthcare providers and what they can do, what can patient and community partners do, healthcare systems, as well as policymakers. So for healthcare providers, I love this quote from Gandhi who says, "Be the change that you want to see in the world." So respectful care starts with me as a provider, as an individual. But with that, and this is a study from Harvard, 60% of providers believe that the quality of care is different by race, so that we're not providing equitable care, but only 40% thought that the difference applied to their patient panel. We have something's not right there, right? We know from the data that we're not providing equitable care. And so we cannot be so oblivious or so arrogant to say, well, it's just those doctors over there. No, you have to look at your own practices and your own self and your own biases to see how you are contributing to that. One way to assess your bias is through Project Implicit through Harvard, and that's to do the implicit association test. Many of you, I'm sure, have seen this link before, but the implicit association test allows you to check your biases in a ton of different ways, whether your bias be in race and for race, bias for ethnicity, size bias, just dark skin, light skin. You can check your bias in a lot of different ways. And that really is the first step. Once you acknowledge your bias, then you can start to work on it. Now, I've already mentioned that biases are unconscious beliefs. So biases are really like a habit, and it takes a long time to break a habit, and biases are not any different. It requires longitudinal work over time to be able to turn your bias around. In doing that work, it's about seeing people as individuals and not the groups that they represent. So seeing Veronica as Veronica and not everything that I, in my biased mind, have associated with Black women or women from the South or whatever, but seeing individuals as individuals. Recognizing that if you have a belief that is a stereotype that comes from this social conditioning, as we talked about before. Increase your opportunity to have contacts with individuals from different groups. If your conditioning is only through social media and through social, and you've not had those experiences, then you are more likely to have beliefs that are based in stereotype. And then above everything, put yourself in someone else's shoes so that we can have empathy. Patient partnerships. So it's so important to partner with our patients. We have to keep patients at the center of innovations of care. How I am delivering care may be totally received from a patient in a different way. They may not receive it in the way that I am intending. And so I have to talk to my patients and make this a partnership. Latasha Rouse is a patient partner out of North Carolina. And one of her quotes is that family-centered care is not something you do for a family, it's something you do with a family. And so we have to think about the care that we give to our patients being with them. It's not for them, it's not to them, it is with them. And that means letting them talk and hearing what they have to say about the care. If you're looking for standardized tools to measure how your patients are receiving care, there are three. There's the Mother's Autonomy and Decision-Making Scale, the Mother's on Respect Index, and the Mistreatment Index. And these are three validated tools that are surveys that patients can complete to give you some feedback on their perception of the care that they are given. And as we think about patients as partners, what does that really mean? So in healthcare, much of how we were trained is very prescriptive. I am the healthcare provider. I went to school, so I have all the knowledge. So I'm going to create the plan, and then you, patient, are going to follow this plan. Well, we know that that does not work. And I do not want to hear one other provider say that a patient is non-compliant. That term should be just erased from our vocabulary and just erased from healthcare in general. If I am telling somebody what to do and I'm not getting their buy-in or explaining to them why I'm making this recommendation, how can I expect them to then follow that? So I don't believe in non-compliance. I believe we didn't make a decision together. And so when we get to shared decision-making, it is about the provider and the patient developing the plan together. But even with this, the patient's roles and responsibilities are still not included. And so we really want to get to partnership, where we have a mutual agreement on the plan, the decisions, and including a shared accountability. You are going to be patient. You will be transparent with me on what is going on for your care. And I, as the doctor, will include you in the decision-making process that we can make, so we can make sure that we are coming to a conclusion about your care in a way that we've done this together, that is something that we have decided on, and not me just telling you what to do. And then healthcare systems, how do they play in respectful care? We have to explore different pay models. We have to move from volume-based care to value-based care. We talked about how time is a factor in being able to provide high quality care. So we have to think about how do we make it important important from a financial standpoint to give quality care and not just a numbers game. We have to create those systems that promote a culture of respect by creating accountability. As I mentioned, when we have disrespect and acts of disrespect within our healthcare systems or whatever system we're talking about, what happens? Where is that accountability? Is having an act of bias, is that viewed the same as a medical error with the same level of accountability? We have to engage in support. And again, we have to partner with our patients and families to have that culture of respect. And then policymakers play a huge role. I've just named a few things here, but these are just some examples of policies that are happening nationally. Like I said, this is a very limited list, but California has passed a bill requiring implicit bias training for physicians, nurses, and allied health professionals. We in Louisiana have an urgent request requiring the same thing. We have the Black Maternal Health Momnibus. This is a congressional movement to improve respectful care and improve quality care. Part of the Momnibus Act is to grow and diversify the perinatal workforce to ensure that every mom in America receives culturally congruent maternity care and support. As I mentioned, if we look at just our physicians, we do not have a diverse workforce. And there's plenty of data that shows when there's concordance of race between the patient and physician, you have improved outcomes, you have improved trust. And so we've got to grow and diversify our perinatal workforce, and not just our physicians, but our nurses, our doulas, our midwives, everywhere, everybody that takes care, social workers, everybody that takes care of patients. To that point, Louisiana, through in our last congressional session, have created a doula registry that we will then be able, hopefully, to be able to apply for doulas to be an insured or covered under insurance. Right now in Louisiana, doula service is not a covered service under insurance. And so only those patients that can afford doulas pay out of pocket are the ones that are able to access them. Now, I'm going to talk to you more about the Perinatal Quality Collaborative in Louisiana and kind of what we have done to link quality to equity. And hopefully this will give you some additional tools and things to think about that you can also employ in your state. So the Louisiana Perinatal Quality Collaborative launched in August of 2018. And we launched after we had released our maternal mortality report. So we had not had any maternal review for 10 years prior to that in 2008. And so this report that was released in 2018 was really a quick view of only pregnancy-related deaths, so deaths that were because of a condition of the pregnancy, within either at the time of pregnancy or within 6 weeks of the end of pregnancy. And it reviewed data from 2011 to 2016. During this review, they found that hypertension and hemorrhage were the leading causes of maternal mortality, and that 4 Black women die at a rate of every 1 white woman. Now, we have put out 2 additional reports, just put out our 2018 review, and we put our 2017 report last year, where we now review all causes of death. And at the time of pregnancy or within 1 year. And so we know the other social factors that are leading to our maternal mortality rate. But again, this particular review is a quick expedited review, only looking at pregnancy-related deaths. So out of that, with the launching of the Louisiana Perinatal Quality Collaborative, we came up with our aim of what we were going to work on. And so we launched our Reducing Maternal Morbidity Initiative with a goal to reduce maternal morbidity or severe maternal morbidity related to hemorrhage and hypertension by 20%, as well as to decrease the Black-white disparity gap from August 2018 to May 2020. In terms of equity, we were very unique as a perinatal quality collaborative. Most collaboratives either worked on hypertension or hemorrhage, and even AIM, the Alliance on Innovation in Maternal Health, made bundles around hemorrhage and hypertension. Nobody was working on equity. Eventually, AIM came back and made a separate bundle on equity. This is far after we had launched. And now they have put equity into all their bundles. I would like to say that we have become a model for that. But we were very unique in that we made a very strong decision that we were not just going to work on improving outcomes if we could not improve outcomes for everybody. And so we doubled down. It was definitely an uphill battle, but we definitely focused on that. And so for us, through our Perinatal Quality Collaborative, we believe there's really 4 drivers. No matter what we are trying to improve on, there's really 4 drivers: reliable clinical processes, respectful patient partnership, effective peer teamwork, and engaged perinatal leadership. From an equity standpoint, that is always built into everything that we do. And that's in that respectful patient partnership. That is designing partnership in care delivery and transparent communication for trust. And so again, it is baked into all that we do. And along with that, not only did we design it into the activity, but we helped to create a culture of equity. We made equity a priority by putting it as a goal. And then we started to teach our birthing facilities that were a part of the collaborative about equity. Again, this was in 2018. So this was before many people were having conversations about equity and bias and structural racism and any of that. So we started with just getting on the same page, speaking the same language, just educating our patients. As I mentioned, it was an uphill battle. So when we had our in-person learning session, it was our second learning session. This is in October of 2018. Again, we made that learning session just about equity. Some of the same things that I've gone over with you. What is the difference in equality and equity? What are the difference in health disparities and healthcare disparities? When I tell you that 2 of our teams were offended that we were having the conversation and walked out in the middle of our presentation, it is amazing to me that we are where we are now as a collaborative, where our hospitals are actively working on equity. Those 2 hospitals did rejoin the collaborative, and we continued down this road. But it became a fork in the road. Where do we back off and we maybe don't talk about equity as much because maybe people aren't ready to have that conversation? Or do we double down, and because we know it's the right thing to do we go down this path, knowing that it's going to be a rocky path? And we made the decision to go down the rocky path because it was the right path. And again, we've made a lot of strides with our teams. Again, you have to make equity a priority. And one of the ways that we continue to reinforce it is with something called charter chats. So we meet with our perinatal quality teams usually every quarter, and we do what's called a charter chat and come up with a 30, 60, 90-day plan. And basically all that is we have an overall aim for our collaborative. what is your aim in your individual hospital? What can we do in 30 days to get to there? What can we do in 60 days? What can we do in 90 days? But if you look here at this template, you can see that patient partnership and equity is a goal that our hospitals have to be working on this constantly. And again, just making it a priority for us, the collaborative making it a priority has made it a priority for our teams. And then the last way that we've done, the last work that we have done around equity to make it a key goal is something called our Louisiana Birth Ready designation. So we just designed this designation, just awarded the first round of designations in August. And it's a designation to distinguish those birthing facilities that are committed to practices that promote a safe, equitable, dignified birth. And in this designation, our hospitals have 5 different key areas that they have to meet: participation, addressing health disparities and patient partnership, policy, procedures, structures, processes, outcomes. They have to work on all of these. But again, one of these is addressing health disparities and patient partnership. We give them a menu of things that they can do, from implicit bias training for nurses and providers to providing a mechanism for patients and families to provide feedback that leads to tests of change. So not just a CGCAP score that says, I rate my experience a 5. No, a way to do, like, calling your patients that have been discharged to see, hey, what was your experience like? And then using that feedback to change how we do things. Having that patient or family partner as part of the improvement team, and then having staff training in family-centered care. I didn't put the slide in, but for our final results for the reducing maternal morbidity, we did reduce severe maternal morbidity from hemorrhage by 35% and by 49% for Black women. We saw not quite as much improvement in the severe maternal morbidity from hypertension. I do think that COVID played a part of that. We now know, and is published, that having COVID-19 in pregnancy is an independent risk factor for developing hypertension in pregnancy, a hypertensive disorder, severe preeclampsia in particular, which then already increases your severe maternal morbidity related to hypertension because of COVID. So we saw a bigger improvement in our before COVID came, but our final result was a reduction in severe maternal morbidity from hypertension by 12%. But we did see an increase in Black women, but we also know that we had disparities where Black individuals experienced COVID-19 and severe complications at a rate higher than that of the other population. So just in summary, before we start to answer questions, respectful maternity care is necessary for quality and safety. So you cannot have a conversation about quality without talking about equity. It is essential. We always have to recenter the work to the who and the why. We have to make sure that care is equitable by making sure it's better and to making sure that it's consistent. And I always end with this picture and just a thought to leave you with. So this picture is of Simone Landrum, who is a birthing person in Louisiana, and Latona Jiwa, who is a doula. I don't know Simone, but I do know Latona, and I know the person that wrote the story. This was in the New York Times, and this person served as Simone's surrogate mother during her birth. So for Simone's story, she had a birth. This was not with Latona, but she had a birth. Just had a stillbirth at around 22 weeks, and obviously was a bad experience. So for her second pregnancy, she decided to have a support person, and so she chose Latona to be her doula. And so for all intents and purposes, for what we consider a good outcome, Simone had a good outcome. She delivered a baby, a healthy baby, term, no complication. She and the baby went home fine, no issues, no problems. But if you ask her what was in the story about her experience, she said the resident physicians came in, did not even address her, talked to each other. Do you want to check her cervix? As if she was an experiment. They made decisions about her care, did not involve her. People talked around her. Nobody talked to her. And so I would say that she felt and walked away with the same feelings of loss in that second birth as she had in the first birth. And so I think about Simone, and Simone looks like me. And I think about my birth story. I had a great birth story. I had no issues. I had no problems. I was treated well, but I also delivered in the same hospital where I deliver care. And so I just wonder if I walked in that hospital and I was Veronica and I was not Dr. Gillespie, what would my birth story look like? Would it look more like Simone's birth story? And so what I want to leave you with is that privilege, no matter what that privilege is, should never be the gateway to respectful care. So my privilege as a doctor should not be why I got respectful care. Someone else's privilege because of the color of their skin should not be the gateway to respectful care. It is something that each and every individual that walks in front of us deserves. Everybody deserves respectful care. And with that, I will be happy to answer any questions.
Thank you so much for that. We do have a great question in the chat box. Minnesota passed legislation this year. Oops, my chat moved, hold on. Passed legislation this year to help diversify the perinatal workforce and to create an implicit bias curriculum for L&D staff. Funding is just being released, but would love to hear your thoughts on benchmarks for us to consider in year 1 and 2. I also wanted to note that part of that legislation in Minnesota this year was also addressing some of the birthing in prison. And I am not an expert on that, so I won't speak on it, but we are hopefully making some forward momentum on that. But if you could speak to that question, and I actually have the link to that New York Times story handy, so I can share that in the chat box. I was looking at that again.
So that is awesome, and that's wonderful that Minnesota has been so progressive from a policy standpoint. With creating that implicit bias curriculum, so one thing to think about, and this is, I can speak kind of what we have been working on here in Louisiana, is all curriculums are not created equal. So thinking about what components need to be in that curriculum. So for our urgent request, it was that the Louisiana Department of Health would determine what those components are. And so, you know, and with your legislation, I'm not sure if you are creating the curriculum that everybody is going to use or that everybody has to do the training. Things to think about in that component would be making sure, in the curriculum would be a component around just level setting, like for some of the things that we've talked about today. The next component would be, how do we see implicit bias? How do we see it manifest in care? As we've talked about through microaggressions, as well as differences in healthcare delivery. Then just understanding your own individual bias. And then the fourth part being my recommendation. Fourth part being case-based scenarios so that you can continue to practice undoing your bias. Again, it's not like something that you're going to do a training on Tuesday and then on Wednesday, now you're not biased and everybody gets the same care. It doesn't work like that. So you have to be longitudinal and intentional with doing that bias training. So even thinking about, and this was in our urgent request, that bias training happen on an annual basis, that it not be just a one and done, but just thinking about some things around that.
And I did share the link to the New York Times article in there. Does anyone else have any questions for our presenter today? Well, thank you for that, Dr. Gillespie Bell. Again, when folks close out, if you fill out the survey there, you will get a certificate of completion. And there was a link posted earlier as to where the presentation will be viewable later. So thank you again for your time today. We really enjoyed this. It was very informative. And we hope to see folks again soon.
My pleasure. Thanks, everyone.
All right. Thank you.